Dear colleagues, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This time we preview the upcoming late-breaking trials at the ACC 2023 in New Orleans. As always, I do this preview together with my good friend and colleague Joost, Daemen. And let's start with some structural trials that will be presented. And first, I would want to start with Triluminate. Triluminate is the first of its kind. It's a randomized controlled trial evaluating tricuspid repair, transcatheter tricuspid repair with an edge-to-edge technique versus medical therapy or guideline-directed medical therapy. And obviously, for the treatment of tricuspid regurgitation, we have diuretics, and that's about it. 350 patients have been enrolled and then randomized one-to-one to either a TriClip or guideline-directed medical therapy. And Paul Saraja will present for the first time the primary outcome of the study. The primary outcome is a hierarchical composite of all-cause death, and then also a composite of need for tricuspid surgery, hospitalizations, and also improvement in quality of life. I think it is kind of a special study because, again, it's the first of its kind, but there are also a couple of unknowns from an outsider point of view. So I'm very much questioning how was patient selection being done, because obviously you cannot do a transcatheter edge-to-edge repair in all patients with tricuspid regurgitation. And also how is the issue of ICDs and pacemakers taken care of? Because we also know that a lot of, or many patients with tricuspid regurgitation have TR because of their device that is running across from the right atrium to the right ventricle. So those are some of the unknowns. I think it's going to be very difficult to find meaningful effects on hard clinical endpoints at 1 year. So I'll be interested in the effects, obviously, on the TR. I would assume that the TriClip will be able to reduce tricuspid regurgitation, but how will it affect quality of life and 6-minute walk test? How will it affect functional capacity of those patients? Those are the data that I'm looking forward to, Joost.
Yeah, totally agree. I think it's an interesting study, and it's probably one of the first that we will face for tricuspid disease in the coming decade. I mean, the COAPT-like trials are urgently needed. Yeah. Also in the tricuspid space. I do have a little bit of an issue with an endpoint combining mortality and very soft endpoints like KCCQ scores. So I'm not sure how we're going to interpret this an endpoint like this in a study in which mostly I assume patients be enrolled that are elderly, inoperable, in relatively poor quality of life conditions. So let's see. But I think the authors already should be congratulated for performing a study like this, which is urgently needed.
And it will set the stage for many more trials in that regard. There's another trial, but then on the mitral valve. It's the UK mini mitral study. This is a randomized controlled study from the UK involving 316 patients randomized one-to-one to either minimal invasive mitral repair or conventional open heart surgery with mitral repair. The primary endpoint is already at 12 weeks following surgery, and it is basically the quality of life of the patients. Luckily, there is also a echo core lab involved to evaluate the effects on MR reduction early, but also at 1 year. And then there is a follow-up out to 5 years to look at key clinical and health economic outcomes. I'm not sure whether they're going to present all the data, but I do feel that it's going to be interesting to see how, in a prospective study, minimal invasive surgery performs with conventional open heart surgery.
I agree. Interesting concept. However, again, talking about the endpoint, I mean, as of 36 as a primary endpoint, you know, it's a score with 8 domains, domains ranging from vitality to physical functioning to pain to all kinds of specific areas in which the patient needs to answer a variety of questions. Yeah. Relatively soft, but yeah, I'm looking forward to the findings. I think if positive, people say yes, indeed, minimal invasive is better. If negative, would that withhold the surgeons nowadays to do mini mitral repair? I don't know.
But you know, in a prospective randomized controlled study, that has never been established, right? So that's why this study is of interest.
But that's why mainly the secondary endpoints to me are perhaps more interesting than the primary. But that said, more on structural and COAPT.
Yeah, so more on mitral regurgitation, and we are all familiar with the primary results of the COAPT trial that were published already almost 5 years ago in 2018, when the MitraClip was evaluated in patients with HFrEF and functional mitral regurgitation. 614 patients, and at 24 months, the MitraClip cohort was outscoring the patients in the cohort with guideline-directed medical therapy only. In terms of rehospitalizations and mortality, obviously a very selected set of patients with a screening committee that was involved and that also turned down a lot of the patients that were screened for the study. So in terms of generalizability and applicability to our everyday clinical practice, we need to be more realistic, I feel. That said, it's interesting to see how many patients will survive at 5 years, because we have to bear in mind that we're talking about HFrEF patients, and you would expect a mortality rate, annual mortality rate of 10%. So you would expect almost 50% of the patients died at 5 years. So we'll see whether that happens. And then in the surviving patients, you also want to evaluate the durability of the MR reduction with TEER. So is this effect lasting out to 5 years from an MR reduction point of view, and then will it translate into better outcome?
Yeah.
Interesting.
To me, the primary endpoint at 5 years has little value. I mean, the study proved its point at 1 year, 2 years, recently even at 3 years. So I mean, there's no argue that the event curves remain clearly in favor of the clip arm. But what will be interesting, at least to me, is in these patients what the durability of the TEER itself will be in terms of MR at the longer run, and I think that will put the therapy in perspective in terms of durability. Also, when we would like to apply it to low risk patients and so on.
And we also have to bear in mind it's a first generation MitraClip device. We now are working with 4th generation devices, so we're only getting better in that regard.
Alrighty, Evolut low risk, 3 year, more long-term follow-up.
Yeah, more long-term follow-up of a randomized controlled trial that had its primary endpoint already published in the New England Journal several years ago, this time in I think 2019. In Evolut low risk, we're talking about patients with severe symptomatic aortic stenosis randomized to either the Evolut platform versus surgery. The mean age of the patients was 74 years old, the STS score was below 2%, and at 2 years the TAVI seemed to be non-inferior to surgery. But the interesting part was in the early publication in the New England was that only 70% and 65% in the both cohorts reached the 2-year end mark. So this was a Bayesian analysis, and the median follow-up of all the patients was 1 year. So the Bayesian analysis allows you to predict the outcomes at 2 years. So there's always, yes, but what if the Bayesian analysis was not effective? So it most often doesn't happen. In Surtavi, they did the exact same statistical analysis plan and it turned out to be quite reproducible. Now we'll see how it behaves, this Bayesian analysis, with the Evolut low risk, but the interesting part is probably we will get a 3-year follow-up of all the patients, and that is going to be of interest. I don't think there is going to be a difference in bioprosthetic valve degeneration out to 3 years, but we know that the valve performance of TAVI is superior to surgery, at least with a self-expanding supraannular functioning valve. And does that translate in different outcome in terms of mortality and rehospitalizations? That is the big question.
Yep, looking forward. And up to the coronary space.
Yes, we move to the coronaries, and that's another trial that had its primary endpoint or outcome already published in the New England Journal, and that is the revived BCIS. And this is a trial of patients with ischemic cardiomyopathy randomized to revascularization with PCI or guideline-directed medical therapy, and the trial was a negative study. So at 1 year there was no difference in the outcome of death or heart failure rehospitalizations, at a median follow-up of 41 months. It was of interest that in the PCI arm there was an improvement in quality of life at 1 year that no longer existed later on in the study. I assume that at this point at ACC they will present a sub-analysis looking at myocardial viability and the effect of the viability studies on the trial results. But I think taking one step back, we were already quite critical from the start, because in this study the majority of the patients were asymptomatic. Yeah. So why would we then send these patients to the cath lab for a revascularization? So that was a little bit of a difficult to understand from my end, because that does not reflect our clinical practice. We would not send a patient with an ischemic cardiomyopathy who is asymptomatic to the cath lab for revascularization, and obviously that will bring this study involves patients that we hardly see in our practice. So again, the adoption to our clinical practice from this trial is limited, in my opinion.
Yeah, again, I think conceptually a very interesting study. The investigators obviously did not anticipate or did not aim to have a population with 65% of patients being asymptomatic. No. But with 2 patients per site per year enrolled, I mean, I think that attests to the selection that has been subject to the population of this trial. Yeah, quality of life was better in the PCI. I'm not exactly sure what this subgroup analysis or post-hoc analysis will contain, but we'll see.
Stay tuned, yes. So let's move on now to the PCI arena, and we start with Renovate Complex PCI. What is that?
Yeah, Renovate Complex PCI is an international multi-center trial from South Korea, randomizing 1,640 patients to a IVUS-guided PCI, or imaging-guided PCI, I should say, versus angio-guided PCI approach in a 2x2 factorial setting. So meaning next to the IVUS or OCT guided revascularization versus the angio-guided revascularization, they will also be randomized to the use of drug-coated balloons or DES in a setting in which patients need to have complex disease, so osteolesions, long lesions, CTOs, etc. So an interesting study, but with the caveats that we will at the end be confronted with the results of patients that have been subject to a treatment with a drug-coated balloon, which is not yet standard of care, I would say, in complex PCI. And mixing OCT and IVUS also in a complex setting, which is to me not really intuitive. We know that there are cases in which you would prefer OCT above IVUS and vice versa, specifically in the setting of complex PCI. Again, a South Korean study. We have learned over the past decades that the investigators keep surprising us with the usually positive trials. So I'm looking forward. I think the study will be positive, specifically with respect to the imaging endpoint. But it's a trial that is preceding several randomized controlled trials on the subject, being improved, being iSTEMI, being IVUS chip. So there's a large series of large international multi-center randomized controlled outcome trials, which will hopefully result in a higher level of evidence to get imaging in our guidelines. But now, first, Renovate Complex PCI.
And it's relevant that this study is coming there from South Korea, because we know that the Asian countries, notably South Korea and Japan, have the highest uptake of invasive imaging. So they are the most experienced. So if we see some kind of a signal there, it will probably also predict the results of, for instance, CHIP IVUS, which is a large randomized controlled study ongoing now here in Rotterdam and globally.
Yeah, no, that's a very relevant comment indeed. So the 8 randomized controlled trials and a wealth of registries that are available on the superiority of imaging guided PCI are coming from the Asian countries. Yeah. Yeah. And that for sure does not represent, as you rightfully mentioned, the Western practice. But okay, more on coronary revascularization is coming from the Biovasc trial. So Biovasc is a multi-center randomized controlled trial comparing immediate versus stage-complete revascularization in patients presenting with ACS. The study was actually initiated here in Erasmus by Nicolas together with Roberto Diletti. International multi-center in Europe, 1,500 patients were enrolled, and Roberto will present the primary endpoint, which will be a composite of all-cause mortality, MI, repeat revascularization, and cerebrovascular events at a 1-year timing.
Yeah, obviously we are highly conflicted now, so
yes.
we cannot comment on the outcome, but I think this is definitely a relevant study because for the first time we look prospectively in how to do a complete revascularization in a patient with ACS, and there is a subgroup in STEMI and a subgroup with non-STEMI, and I think we'll get practical information that may help guide practice, everyday clinical practice. So we'll get back to that in our wrap-up. Yes, sir. But let's move on to statins, and there's always a lot of drug therapies at ACC. So what have we now?
Yeah, so statins, but not just statins. I would say therapy for dyslipidemia as well as therapy for hypertension is one of our typical topics that we like to cover in our previews and wrap-ups. This year, three studies actually would like to highlight on dyslipidemia. One is the Yellow trial, which is still an interventional trial. So Yellow 3 is a interventional trial, 140 patients with chronic coronary syndromes undergoing a PCI. Will have a multimodality imaging with IVUS and NIRS IVUS and OCT of a non-culprit artery with, in case of an intermediate coronary lesion. All patients will receive evolocumab at baseline, from on baseline, on top of routine statin therapy, and will be re-evaluated at 26 weeks. So with that, the Yellow 3 trial is the missing link in the spectrum of data that we have now for evolocumab. So you all know you have Glagov, we have Huygens demonstrating that the addition of evolocumab as compared to placebo helps to significantly decrease percentage atheroma volume, cap thickness and plaque volume in general, and lipid arc as identified by OCT, I should say. Whereas with alirocumab, with Pac-Man, which was a little bit of a more complete trial, everything was shown to be positive. Less percentage atheroma volume with alirocumab as compared to placebo, 2% decrease. A decrease in the lipid core burden index and a stabilization of the plaque with a increase of the cap thickness. Yellow 3 is the missing link for evolocumab, now finally telling us whether the addition of evolocumab will help to decrease the lipid core burden index as compared to baseline in patients with chronic coronary syndrome.
Yeah, definitely high expectations for this specific set of medical therapy for lipid lowering and the PCSK9 inhibitors. Unfortunately, it is still in terms of reimbursement a challenge. We cannot put all our patients who are at high risk of coronary events on these drugs, but I do feel that this is the way to go. The lower we can get these cholesterol levels, the better. And there is also another trial in that regard, and that is the CLEAR Outcomes trial. And this is a study evaluating bempedoic acid in patients who are intolerant for statins. And a respectable number of more than 14,000 patients are randomized 1-to-1 to either bempedoic acid or control. Steve Nissen is going to present the outcomes of that trial, and the primary composite endpoint is typical composite endpoint of cardiovascular death, myocardial infarction, non-fatal stroke, or coronary revascularization. The estimated follow-up is almost 4 years, and the question then is, okay, is bempedoic acid really effective, and also, does it come with fewer side effects than statins? Because bempedoic acid, like statins, works on the cholesterol synthesis in the liver, but it is a prodrug that is not metabolized in the muscles, and that is the part of the statins that may be responsible for these muscle pains in patients on statins that obviously will not happen in patients with bempedoic acid. So first there is the outcome, will it reach its primary endpoint, and then it is what about side effects. But if everything points in the right direction, then I think we are on the, we can expect multiple randomized controlled trials in the near future with bempedoic acid in patients with chronic and acute coronary syndromes.
Yeah, I totally agree. This is one of the drugs that will likely have the potential to change our practice, irrespective of the mechanisms of action, irrespective of the potency of the drug. I think patient adherence is critical here. And I think the study is very cleverly designed in a way that they only enrolled patients with a statin intolerance, and we all know that maybe pertains only to 5% of the patients. So those
in
patients,
the trials, but in our practice it's 1 in 5. Eh?
But that's what I'm saying. So it's at the end it's all about patient adherence, and then you have 1 in 5 that admits he has muscle pain, but then you still have 1 in 2 that says I have no pain, but they don't take their drugs. Yeah. And in case patients do tolerate this better, I think we have a strong agent that has the potential to maybe replace statins in a large amount of patients. And at the end, irrespective of what type of drug the patient takes, it will help to improve outcome because, again, the lower LDL, the better.
Yeah. But
Good.
There's more?
There's one more agent we would like to mention very briefly is MK0616, which is a code name again for a novel agent. And this is the Merck agent, which is one of the first, or maybe the first, I'm not sure, oral PCSK9 inhibitor. The drug demonstrated already to be very potent, 65% LDL reduction on top of statins as compared to statins alone in previous data.
And that is similar to the parenteral?
Yeah, similar to the subcutaneous. Yeah, and in this case, it's a phase 2 trial, 316 patients who were randomized to 4 doses of MK0616 versus placebo. Obviously looking again for safety and efficacy, but also an agent that may become very appealing to a large category of patients, obviously depending on how this will be marketed and priced, but I think it's something to look out for.
And against side effects. Huh?
And again, side effects.
Yeah. Patient tolerance. Okay. Good. With that, I think we have something to look forward to at ACC in New Orleans. Thank you for staying with us for this preview, and we hope to see you back after ACC for the wrap-up from the Thoraxcenter. Thank you very much.
Bye-bye.